going first?
It will be the resident.
Okay, great.
So good evening, everybody, for this HPB cafe. Good evening and good morning, for those who are like in the morning time. We are so happy and we have the pleasure and the honor to have Professor Pawlik with us in this HPB cafe. Professor Pawlik currently is the chair of surgery at the Ohio State University Wexner Medical Center, where he holds the Urban Meyer III and Shelley Meyer Chair for Cancer Research. He did his advanced training in surgical oncology at the University of Texas, MD Anderson Cancer Center. His main clinical interests include alimentary tract surgery, with special interest in HPB disease. He also has an interest in medical ethics and completed a fellowship in medical ethics at the Harvard School of Public Health, as well as master in theology from Harvard Divinity School in Boston. He has given over 600 invited talks, both nationally and internationally, in more than 35 different countries. He has published over 1,750 articles and more than 125 book chapters. In addition to editing 16 surgical textbooks. Professor Pawlik's research focuses on determinations of factors associated with prognosis and staging of GI cancers, as well as economics of cancer care. His research has been cited over 83,000 times with an H index of 141 and I-10 index of 1,000. He serves on multiple editorial boards and he is editor-in-chief of Journal of Gastrointestinal Surgery, deputy editor of JAMA Surgery, as well as an associate editor for Annals of Surgical Oncology. He is member of multiple surgical societies and led previously many of them. But before going to the talks of Professor Pawlik, we'll start with an article presentation by our surgical resident, Ola Al Hamadani. And Ola is one of the active surgical residents in our Oman Medical Specialty Board. So Ola, the floor is for you to present the article.
Thank you.
Welcome.
Thank you, Dr. Abdullah. I hope everyone can hear me well.
Yes.
All right, great. Good evening, everyone, and good morning, Prof. It's such a pleasure to present in the HPB Cafe. Thank you, Dr. Abdullah Farai, for giving us this opportunity. I'll be sharing the screen. Do let me know that my presentation is clear, I hope. Dr. Abdullah, can you allow me to share the screen?
You are allowed, yeah.
Oh, all right, okay. Everyone can see the screen?
Yes.
Yeah.
All right, so I was given the article to present whether we should proceed with lymph node dissection in intrahepatic cholangiocarcinoma. So I titled it as to dissect or not to dissect, aggressive versus thoughtful approach. All right, so just a brief introduction in this regards. Intrahepatic cholangiocarcinoma is an aggressive malignancy, which is mainly arising from the epithelium of the intrahepatic bile ducts. The incidence is found to be increasing globally, and only 20 to 40% of the patients are candidates for resection. The 5-year survival rate, the average is between 25 to 40%. And that's mainly in the early stage of the disease, and the recurrence rates are found to be as high as 50 to 70%. The reason why we're proceeding with this discussion back and forth is because lymph node mets in intrahepatic cholangiocarcinoma is considered one of the strongest predictive factors of poor outcome. So when it comes to discussion of intrahepatic cholangiocarcinomas, we speak about staging, and the main staging that we use nowadays is the AJCC 8th edition. Between the 5th and the 8th edition, we had multiple variations that occurred. And as far as I believe, Prof. Here was one of the main reasons the 8th edition actually came into place. So between the 7th and the 8th, initially they used to discuss the size of the tumor, and the 7th edition was not completely relevant, but it came back to relevance again in the 8th edition, which more than 5 centimeters was considered a part of the staging. And then obviously we'll proceed with the rest. I'm not going to go into details with that because I believe Prof. Pawlik is going to go into details. So why is this a debate? Why is lymph node dissection a debate? So it's always thought to be primarily a staging procedure and not therapeutic. It does not actually provide any actual survival benefit. And in most of the literature, it's associated with increased post-op morbidity. It is important to note that we actually lack, and there is absence of randomized controlled trials when it comes to lymph node dissection in intrahepatic cholangiocarcinoma. And most published papers actually rely on retrospective studies. So I'll just briefly go into what is currently being practiced or what are the guidelines talking about. So if we go to the NCCN guidelines, we would see that most of the time, the parts that I highlighted, that resection of lymph nodes is actually recommended. So here, the primary treatment is laparoscopy, make sure that there is no mets of the disease, and then resection of regional lymphadenectomy. Once again, in the 5th point here, we would see that a regional lymphadenectomy of the porta hepatis is carried out as one of the principles of surgery. And then more or less, this comes back and forth that it is an important prognostic factor and that lymph node metastasis plays an important role in the overall survival of the patients. I did highlight this in red here because it does mention that regional lymphadenectomy of the porta hepatis is recommended, not only because of staging, but because sometimes it was actually associated with better survival rate. This is out of the oncological manual. So we do see here that the clinical outcome and the prognosis of 5-year overall survival is 20 to 25% in patients that are found to be lymph node positive, but is resectable, and less than 5% in those that are not resectable. And then once again, even in the surgical oncological manual that we all study now in residency, it does say that the management is emerging evidence that recommendation of a routine high-layer lymph node dissection for its prognostic value. Very briefly here, this has been discussed back and forth. If you see the lines between blue and yellow here, you do see that solitary lesion with regional lymph node mets actually has a very significant effect in the proportion of survival. And then obviously if it's multiple lesions, it's even worse. But the reason I pointed this out here, because we always speak whether it's solitary or multiple, if it's vascular invasion or not vascular invasion, but all of this becomes insignificant when it comes to lymph node metastasis. Before I go into the article, I just want to mention that more or less most of the papers mentioned that for you to actually talk about lymph node dissection, we talk about harvesting more or less 6 lymph nodes, which is very difficult to establish. So the paper that I'm going to be discussing is the value of lymph node dissection in intrahepatic cholangiocarcinoma, which is a systemic review and a meta-analysis. The objective of the paper was that to investigate the effect of lymph node dissection on survival outcomes and morbidity following resection of intrahepatic cholangiocarcinoma. And to accomplish this goal, the data was pulled from several high-quality multi-center studies, and then a subset analysis was performed further to assess the impact of lymph node dissection and survival among intrahepatic cholangiocarcinoma patients who did not have pre-op evidence of lymph node mets. So the eligibility criteria in this paper was, in order to limit the effect of unbalanced covariates and reverse schedulability and selection bias, the studies were included were those that utilized propensity score-based methodology. And those studies that include extrahepatic cholangiocarcinoma, other liver malignancies, non-comparative studies, non-English studies, and non-human studies were all excluded. The way this was approached, that there were 3 reviewers independently that extracted the data. This included first author, the year that the paper was published, study country, period of enrollment, number of patients, age, male, sex, tumor size, the value of CA19-9, definition of lymph node mets, negativity, resection margin, number of lymph nodes retrieved, and pathological lymph nodes. mets, and major complications, overall survival, and disease-free survival. So just going through the papers that were included, we'll start, they started off with 985 papers. And then after removing the duplicates and with the exclusion, we ended up with 707 papers. Process went further and exclusion went further, and they ended up with 24. And then there were some overlapping patient cohorts and some pathological diagnoses and outcomes of no interest. So we actually ended up with 8 papers. Just going through the papers. So 7 out of the 8 were multicentric studies. Only through included patients outside of Asia. I believe those were in Italy, France, 2 in Italy and 1 in France, and 5 were assessed to have low risk bias, and 3 were characterized as moderate risk of bias. And if we go into these, the 3 were mainly due to either the selection of the participants or due to missing data. So what did this meta-analysis result in? So as I said, the main outcomes were either overall survival, disease-free survival, or major complications. So if we have a look at this table and diagram, it includes all 8 papers, all 8 studies that are within the meta-analysis. The 8 studies included 3,776 patients in total. 2,087 were those that underwent lymph node dissection. 689 were those that did not undergo any lymph node dissection. And as we see here, it does actually favor lymph node dissection with a heterogeneity rate of initially 82%. And then after having the subgroup analysis, we ended up with a rate of 0%. And then when it comes to the second goal of the paper, which is disease-free survival, this included 5 out of the 8 papers, ending up with 1,414 patients, and 856 were in the lymph node dissection, 558 were in the non-lymph node dissection group. And it does, once again, favor the lymph node dissection with a low statistical heterogeneity of 22%. And more or less the same heterogeneity was there after the subset analysis. And then when it comes to the major complications, once again, we had 5 papers out of the 8. And in this case, the 5 studies included 1,773 patients. 1,020 were those that underwent lymph node dissection, and 753 were non-lymph node dissection. And it was quite equivocal, but leaning more towards the non-lymph node dissection group that would not have major complications. Nonetheless, it is important to mention that in all outcomes, be it overall survival or disease-free survival or major complications, the statistic difference to take a decision was not actually significant. So when it comes to discussion, the study, as I mentioned, found that lymph node dissection during surgical resection did not increase overall survival, did not increase disease-free survival, but was also not associated with significant post-op major morbidity with the lymph node dissection group. The N0 are a very important subgroup of patients, and this is where usually the dilemma occurs. The meta-analysis and the subset analysis show that pre-op lymph node evaluation is usually done using cross-sectional images, be it CT versus MRI, and MRI being more sensitive and more specific in detection, with a rate going up to 70%. And then there is a paper that was mentioned within the meta-analysis that showed that up to 40% of patients that were thought to be N0 were found to be pathologically positive on the post-op pathology, which highlights kind of that we have some drawbacks in the current pre-op evaluation. So when we come to discuss further why there were some improved survival rates in the N0 patients, surgical lymph node dissection facilitated accurate pathological staging for lymph nodes, which in turn allowed appropriate administration of the adjuvant therapy. And closer post-op surveillance may have occurred due to this detection of the lymph nodes. So when it comes to the limitations of the study, we had significant baseline differences between the patients' cohorts. There is unmatched nature of the included studies, and all studies that were included were more or less retrospective. There is limited information about confounding factors such as the pre-op evaluation of the nodal status, as I mentioned previously, the criteria used to select cases for lymph node dissection, tumor pathological characteristics, patients who receive adjuvant therapy, and surgical technique, as well as most of these lasted for more than a decade. As I mentioned, the AJCC have changed through the years, and a lot of the therapeutic approach when it comes to intrahepatic cholangiocarcinoma or cholangiocarcinoma in general differed significantly within these 10 years. So I'll end my presentation with these 3 questions. So do we actually need to remove every evident lymph node that we see intra-op? If it's palpable, if it looks pathological, am I supposed to proceed with removing it? Does the non-lymph node dissection not make a difference in statistics because of improved chemotherapy approaches? Most of the papers that I've gone through shows that current approaches for adjuvant chemotherapy, which has showed significant improvement in patient survival and patient disease-free survival, have been 2 approaches. One of them is gemcitabine with cisplatin, and another paper showed it being with the GEMOX combination, which is gemcitabine with oxaliplatin. And then once again, the last question that I'm going to mention, is there a role for liver transplant when it comes to intrahepatic cholangiocarcinoma, just like the one that we have for HCC? I did bring up that question, maybe Prof would go through it, because a lot of the time, some cancers were treated as HCC, and in the final pathological histopathology, it was found to be cholangiocarcinoma. That's all. Thank you very much.
Thank you. Great presentation.
Yeah, thank you, Ola. Excellent introduction and dissection of the paper. Excellent, Ola.
Thank you very much. Thank you.
Of course, for any question, please put it in the chat or raise your hand. And maybe this question that you ask, Ola, at the end, I would probably divert them to Professor Pawlik. I don't know, what do you think, Professor Pawlik, about lymph node dissection?
Well, I'm going to cover it in some of my comments I'm going to be making about intrahepatic cholangiocarcinoma. So, you know, I can comment them, but we have long advocated for lymph node dissection at the time of surgery for intrahepatic cholangiocarcinoma. And as Ola noted in the meta-analysis, although there's not a survival benefit or recurrence benefit, we do lymphadenectomy for colorectal cancer and pancreatic cancer and gallbladder cancer, not necessarily because we believe there's a survival benefit associated with it, but we think it's necessary for more adequate staging and stratification of patients with regards to prognosis. And then I would also note that, you know, with intrahepatic cholangiocarcinoma, you know, it can help identify patients who might benefit from adjuvant therapy in light of the BILCAP data. And then also, if people do recur with nodal disease in the hilum, it can be problematic from a management point of view, because these patients can develop biliary obstruction, and it can impact quality of life. So given that it's not associated with any kind of adverse effects or increasing complications, and it does have a benefit with regards to prognosis in informing adjuvant therapy, I am a proponent.
Okay, great. Anybody from the participants, if you have any question? Professor Benaro is joining from Italy. Hi, Benaro.
Hi, how are you? Hi.
Good, and you?
Thank you. Hi, team. Thank you very much for the lecture.
Yeah, you bet. Good to see you. I'm really, you know, honored to be here. I appreciate the invitation.
Thank you. We organized, this is the I don't know, is a 13 discussion. We invite some surgeon and an oncologist from all over the world. We invite Giulianotti, Troisi, and you are the best for the intrahepatic cholangiocarcinoma. So we ask if you have time, and because I know that it's not easy for you, because you are all in all the world. I met you several times in
Yes.
all the meeting.
Yes. Yes.
Thank you again.
Oh, it's my pleasure. Thank you for having me. I'm really honored.
More than 600 talks, over 335 countries. I think we can go to your talk, Professor Pawlik.
Okay.
Not to lose your time as well.
Great. Well, that was a great presentation, and I for a second there I thought you were going to give my talk for me. So really wonderful job, and I'm going to touch on some of your points and kind of emphasize those. So yeah, so just to follow up on Ola's talk, I'm going to talk a little bit about intrahepatic cholangiocarcinoma. This is something that my research group and myself have focused on over the last 15 or 20 years. And so it's something I'm really passionate about. The incidence of intrahepatic cholangiocarcinoma has been increasing. Typically when you think of cholangiocarcinoma, you think of perihilar or Klatskin being the most common. But if you look, intrahepatic cholangiocarcinoma has a steeper incline with regards to its incidence, both related to localized disease, but also regional and distant disease. We know that there's significant geographic variation in the incidence of cholangiocarcinoma, with higher incidence in the East than the West. That's largely been due to, hepatitis, chronic inflammation of the liver due to viral entities. But as the demographics begin to shift, and now we have vaccines against HPV and we can treat HCV very effectively, what we're seeing is that more patients are getting ICC because of MALD, metabolic associated liver disease, obesity, and metabolic syndrome, especially in the West. In the East, in some places, and actually I was in Thailand a couple of years ago, and you can see here in northern Thailand, cholangiocarcinoma is almost endemic at 85 cases per 100,000, and that's because of liver flukes in that area. And it's important to know that the etiology of intrahepatic cholangiocarcinoma is different, but that has important implications for kind of like the genetic basis. Not all cholangiocarcinoma is the same. And there's been some good data to show that whether it's initiated by liver flukes or obesity or viral hepatitis, it can have kind of genetic differences when you screen for those. As I mentioned, this is one of the earlier studies that we presented showing that, steatosis, fatty liver can lead to oxidative and metabolic stress that can directly impact the liver. We traditionally think that you have to have steatosis and then fibrosis and cirrhosis, and then you get HCC or ICC. But in my practice, most of the time, I'm just seeing someone who's overweight, obese, has a fatty liver, and then presents with a mass that's intrahepatic cholangiocarcinoma. And this would be a typical case here, this large hypodense lesion in the right hemiliver. And then typically what happens, someone puts a needle into it and it comes back adenocarcinoma. And then the question is this a primary lesion or a secondary lesion? And typically what the pathologist will look for is biliary dysplasia, and do a panel of intrahepatic, do a panel of immunohistochemical staining to rule out other primers like colon or pancreas, and then look for markers that are consistent with biliary epithelium, so they can essentially come back with a diagnosis of adenocarcinoma, highly suspicious for a biliary pancreatic origin. It's important to note that when I'm doing radiographic imaging of intrahepatic cholangiocarcinoma, that there's three major morphologic subtypes. There's the mass forming, and you can see that here. As I noted, it typically is a low attenuating lesion. You can see the capsular retraction here, and then maybe some peripheral enhancement. There's a periductal infiltrating intrahepatic cholangiocarcinoma. You can see here the periductal enhancement, ductal thickening, ductal dilatation. And then the third type is the intraductal growth pattern, where you see this ductatasia. It's this kind of sausage-like change to the duct, and you can see sometimes a visible intraductal papillary mass. But in general, when we're talking about intrahepatic cholangiocarcinoma, we're talking about mass-forming lesions. These are data from the Liver Cancer Study Group of Japan showing that 80% of patients who present with cholangiocarcinoma within the liver will have a mass-forming lesion. And as I noted, imaging is really the workhorse of working these patients up. If you have a good hepatoradiologist, they can very easily differentiate an intrahepatic cholangiocarcinoma from a hepatocellular carcinoma. So typically, hepatocellular carcinoma is a soft tumor in a hard liver. So what you see is early enhancement with late washout. But with intrahepatic cholangiocarcinoma, it's the opposite typically. It's a soft liver, a fatty liver with a hard tumor, lots of stroma, dense, fibrous. So what you see on the scan typically is that on early phases, it's hypointense, and only on late phases will it enhance. So kind of the opposite, if you will, of HCC. And if you see on the CT scan, it's kind of classic. You see this large hypoattenuated lesion, and then you can also see some ductal dilatation. Here at Ohio State, we strongly prefer MRI. And these three panels are really the classic presentation for an intrahepatic cholangiocarcinoma. You see in panel A, early phase, it's hypodense, hypoattenuating lesion. You can see the capsular retraction that I mentioned. On later films, you can see how it enhances. You have this peripheral enhancement, and you have some central necrosis. And then on the third panel, what you can see is this peritumoral ductal dilatation. So really with these images, there's really no question that this is very, very likely an intrahepatic cholangiocarcinoma. I tend to use a fair amount of PET with this disease because it's very PET FDG avid. And about 20 to 30% of cases, you will identify occult metastatic disease, either secondary intrahepatic metastases or perhaps more common, nodal disease, in the hilum or in the second echelon lymph nodes. And if I do identify nodal disease that is PET FDG avid, I am more likely to treat this patient with preoperative chemotherapy before taking them to the operating room. Because as I'll show you, patients who have nodal disease do pretty poorly even after curative intent resection. So similar to pancreas cancer, we've adopted more and more kind of a neoadjuvant approach to these individuals. I think that's also important because these operations are hard and they can carry with them a fair amount of morbidity. So before undertaking a major operation, it's kind of good to get an idea of how much therapeutic benefit will be derived from these large operations. So here's an example of a patient of mine, very large lesion, central aspect of the liver, segment 5, segment 4B. It's taken out the anterior sectoral branch of the portal vein. It's abutting the right posterior sectoral branch. This patient actually had satellitosis. And because of the vascular invasion, the satellitosis, I actually treated this patient with preoperative systemic chemotherapy and then also preoperative Y90 yttrium therapy. I then subsequently took the patient to the operating room for an extended right hemihepatectomy. You can see that here. Here's the umbilical fissure with the umbilical vein. Here's the portal vein. You can see the staple line on the right vein, and then had to remove the complete extrahepatic biliary tree here. And you can see the bile ducts at the base of segments 2 and 3. And this is what it looks like on the explant. So large tumor, big operation. And you can also see sometimes it's hard to achieve wide negative margins because these tumors can be quite large. That's largely because many patients are asymptomatic until late in the course of their disease. Here's another case. This is a patient who presented with a left-sided lesion. You can see the right hepatic vein, but on CT, there was no opacification of the middle or the left hepatic vein. And you can see how it abuts the main portal vein and also the right anterior sectoral branch. So this is another patient that I gave chemotherapy to preoperatively and then subsequently took them to the operating room and did an extended left hepatectomy. This patient actually did well and is still alive about 2.5 years later. That's different than this other patient. This is a patient that presented with a large mass in the right liver. You can see there is a prosthetic endobiliary stent in place because this patient presented with jaundice. You can also see, because of that biliary obstruction, there's the classic atrophy hypertrophy syndrome. You can see the right liver is kind of atrophied and the left liver is quite sizable. And then the other thing you can see, there's actually ascites. This patient had ascites and had a very high CA19-9 of over 100,000. So rightly or wrongly, I treated this patient with nab-paclitaxel, you know, their CA9- came down. It didn't completely normalize, but their ascites went away. I operated on this patient, did a right hepatectomy. This patient recurred and died within 6 months. So I think this these cases kind of emphasize how large these operations are. And even though, like in this case, where the operation was successful and the patient went home and everything was smooth, technically, from an oncologic point of view, it was a very poor outcome with recurrence very quickly after the operation. So as surgeons, what can we control in the operating room to improve long-term survival for these patients? Well, one is the type of operation that we do and the margin that we achieve. We know there's a lot of literature for hepatocellular carcinoma around the importance of obtaining an anatomic resection because of concern that disease tracks along the portal triads. But at least data from our group has shown that there's no benefit to performing an anatomic versus non-anatomic resection for ICC, but rather there is a benefit to achieving a wide surgical margin. And these data demonstrate that patients with at least a centimeter margin tend to have better recurrence-free and overall survival. So that should really be the goal at the time of surgery. These are data from the recent, or actually not so recent because the 9th edition is going to be coming out, but the 8th edition AJCC staging manual, and Ola touched on this. But, you know, pathology wise, patients should really be categorized based on tumor size, bigger or smaller than 5 centimeters, and then also whether there is vascular invasion and whether there is the presence of multifocal disease. And our group and others have validated this staging system, and it really should be used worldwide for how to classify the primary tumor. Our group has also been interested in tumor burden score. So this is an aggregate score because if you have patients with multiple tumors that are all multiple sizes, like how do you figure out like what is the overall burden of disease in the liver, right? If you have 3 lesions and each one are 1 centimeter compared to like 1 lesion that is 7 centimeters, how do you compare those two things? So we have kind of popularized this idea of tumor burden score, and it's an aggregate score that assesses the overall burden of disease in the liver. And this is actually a very accurate score, and it's been validated by others. And what's interesting is that patients who have a high tumor burden, they do very poorly. Their 5-year survival is only about 15%, and their 5-year disease-free survival is only in the range of about 7%. So these data are helpful because if a patient presents with a high tumor burden score, I am much more likely to treat that individual with preoperative therapy than take them directly to the operating room because they have bad biology. And just again, like pancreatic cancer, I want to let the biology kind of sort itself out, if you will, so I can minimize those patients, like the example that I showed you, where the operation is a success, but they recur very quickly and don't derive a real benefit from the operation. The other thing that we've done is that we've used artificial intelligence and machine learning to look at different classifications of ICC, so-called common, proliferative, or inflammatory, with proliferative being characterized by those patients who have large tumors with a high CA19-9, and those patients with inflammatory tumors having a high neutrophil to lymphocyte ratio. And you can see here on the left how the machine learning was able to categorize 3 different clusters of patients. And then we can see on the right that the patients with the inflammatory subtype do particularly poorly with a 3-year survival of only about 13%. So again, some data suggesting that patients with certain types of ICC, like inflammatory with a high neutrophil to lymphocyte ratio, may benefit from preoperative therapy rather than being taken directly to the operating room. Now I'm going to tread a little bit into what Ola discussed. And I'll kind of go through this a little bit briefly because Ola did such a great job covering this. But there's been a long debate around, lymphadenectomy, right? We do it for fibrolamellar, right? Everyone would agree that for fibrolamellar HCC, we should do a lymphadenectomy, but we don't do it for garden variety HCC. Well, if you look at data from our group, and these data are kind of quite old now. This is what we published in JCO, over a decade ago. But, you can see that the overall incidence of nodal disease is about 30%. And even if you consider those patients who didn't have a lymphadenectomy and have the best case scenario that they were all node negative, they would still be about 20%. So we know that the incidence of nodal disease is somewhere between 20 to 30%. And even in T1A patients, it's probably in the range of 10 to 15%. We also know that lymph nodes are a very strong indicator of prognosis, just like pancreatic cancer, gastric cancer, colon cancer. And I would argue that if you do not get the nodal information, you might as well not stage the patient at all, because everything with staging is about competing risk. If you are node negative, what is driving your prognosis are the T factors, right? Vascular invasion. Do you have single or multiple tumors? Once you have nodal disease, you can see here that the T categories, vascular invasion or multifocality, are no longer prognostically important, because what's driving your survival is the fact that you have regional nodal metastases. So if you're going to even use the AGCC staging manual and the TNM staging, you really need to have both T and N. And to do that, you need to do a lymphadenectomy. And to do a lymphadenectomy, you have to be aware of the anatomy of the different nodal basins and the stations. And you also have to appreciate that there's a laterality to the liver. So if the tumor is in the right side of the liver, the nodes will more preferentially drain to nodal stations 8, 9, 12, and 13, and those should be harvested. Whereas if the mass is on the left side of the liver, the nodes will drain to stations 1 and 3, and those should be included in the lymph node harvest. Because our group has demonstrated, here's a paper published in Annals of Surgery, that not only is it important that we figure out whether the nodes are positive or negative, but the station matters. And these data demonstrate that patients who have nodal metastasis in the second echelon lymph nodes, so beyond station 12, those patients do significantly worse than patients with nodal metastasis in the primary echelon. So that's why the staging manual recommends that everyone gets a lymphadenectomy. The staging manual recommends 6 lymph nodes. I was the vice chair of the staging manual when we were making these recommendations. And I'll let you in on a little bit of a dirty secret. There are vanishingly small data to back up the recommendation for 6 lymph nodes. And largely, we wanted it to align with the recommendations for gallbladder cancer. And that's how we kind of ended up on the 6 lymph node threshold. But you'll see, at least data from the United States, that only half of patients even have 1 node evaluated at the time of resection for ICC. And only about 15% of patients get the so-called requisite 6 lymph nodes evaluated. So we're doing a pretty poor job evaluating the lymph node basin, as Ola mentioned. Now, what's the prognosis after all this? These big operations, we're talking about the T, we're talking about the N, and come to find out, survival is pretty poor. And I don't know if anyone else sees this and kind of thinks of another disease, but I look at this and this reminds me of pancreas cancer again, right? And 5-year survival after a Whipple operation was always about 30%. So that's the type of cancer that intrahepatic cholangiocarcinoma is. And even if you look at 10-year data, which we did, this kind of cure rate, if you will, the overall probability of cure at 10 years is pretty low in the range of only about 10 to 15%. And the reason for that is because patients recur. And unfortunately, they recur often, they recur early, and they recur systemically. So here's some data that we published again a while back, showing that even with in 2 years, about half of patients will recur. And what's interesting is that half of patients will have an extrahepatic site as a location for recurrence. So if you've taken out the primary and they're recurring outside the liver, that to me suggests that there was primary disease at the time of operation that was underappreciated, so-called micrometastatic disease, again, just like pancreatic cancer. And that's why there's been a movement, at least in our group, to head towards preoperative therapy more and more. And this is another study that we published a couple years ago in JAMA Surgery, showing that even 1 in 5 patients can have a very early recurrence within 6 months of surgery. And again, there's nothing at least more depressing for the patient, the surgeon, and their family than to have a big operation and within 6 months they have a recurrence and they're not cured. So because of all these challenges around recurrence, there's been a lot of interest in adjuvant therapies. And I know you're all familiar with the SWOG, PREDIGE 12 and BILCAP studies. And basically what these studies show was that the PREDIGE looked at GEMOX versus observation. BILCAP looked at capecitabine versus observation. The PREDIGE was a negative study, whereas the BILCAP was sort of a positive study. You know, on the intention to treat analysis, it didn't quite reach statistical significance, but on the per protocol basis, statistical significance was achieved. So therefore, many of us have adopted adjuvant capecitabine for patients, especially those with high risk features, including nodal metastasis. So I'm just want to touch on a couple other things. You know, I think that similar to colorectal liver metastasis, you know, there was advancements with surgical technique, but really what changed the paradigm was better systemic therapy. And that really broadened the indications for operating on patients with colorectal liver metastasis. And I think the same thing is going to need to happen in intrahepatic cholangiocarcinoma. You know, first line therapy has traditionally been GEM-CIS based on the ABC trial, which showed that doublet therapy was better than monotherapy with capecitabine. But the future really is more targeted therapy, right? And we know that in patients with intrahepatic cholangiocarcinoma, 15 to 20% will have an IDH mutation, 15 to 20% we're going to have an FGFR fusion, and then lower subsets will have mismatch repair mutations, BRAF, HER2. And so there's been a ton of interest lately about a more personalized approach. This is a study that looked at FGFR2 fusions in treated patients with sunitinib targeted therapy, and looked at objective response rate, and demonstrated that even in patients who were heavily pretreated, you can see that, you know, over 50% had 2 or more prior systemic regimens, that they were able to achieve objective response rate of 41% and a disease control rate of 82%. And the duration of this response was fairly good at about 10 months. And survival, you can see here, was, 73% at 12 months. So, you know, there have been other studies looking at FGFR targeted therapy, and this has led for FDA approval here in the United States and worldwide to use this targeted therapy for patients who have FGFR fusions. There's also been interest around IDH1 mutations. And in this Clarity trial, randomizing patients with IDH1 mutational status in a 2-to-1 fashion to isofenib versus placebo. And again, in this trial, there was a 53% disease control rate in the ifosfamide group versus the placebo group. This resulted in a 50% risk reduction in death for treatment versus control. And this similarly has been approved for patients with IDH1 advanced cholangiocarcinoma. Similarly, there's been interest in immunotherapy. And while immunotherapy alone has perhaps not been incredibly successful, combining immunotherapy with cytotoxic therapy has demonstrated success. This is the TOPAZ trial that looked at Dura plus Gem and cisplatin, and this demonstrated a benefit with a 20% risk reduction in death. And based on these data from TOPAZ, this regimen is really considered the standard of care for patients with advanced intrahepatic cholangiocarcinoma. And you can see here that with regards to secondary outputs, looking at objective response rate and durable response, there was a benefit to Dura plus Gem-Cis versus Gem-Cis alone. And then finally, I'll just touch on two other kind of emerging surgical approaches. One is pump therapy. I do think there is a role for patients with liver-only disease for intrahepatic therapy with HIA therapy. And this is a paper that we published with Bas from the Netherlands showing that this is not only safe, but people can have pretty dramatic responses. And there was about a 5 to 7% conversion rate of people who were unresectable to resectable with pump therapy. So it's not super high, but it's also not zero. And I do think that, this is an approach that should be discussed in a multidisciplinary setting, and we do use it here. And then finally, I'll just touch on transplant since Ola brought it up. And I think transplant for intrahepatic cholangiocarcinoma, as you can see here on the left, is really not utilized that much. You can see here compared to liver resection, which is obviously the predominant surgical approach. Transplantation should largely still be considered somewhat investigational and be done on a per protocol basis. That being said, if you look on the right, transplant can have pretty good outcomes, especially in those patients who are well selected and have early stage disease. I think it's just going to be about, appropriate patient selection and appropriate preoperative therapy to ensure that we've identified patients with the best biology to take them to transplantation. So what are some of the take-home points? Intrahepatic cholangiocarcinoma, the incidence is increasing. We're all going to be seeing it more and more in our HPB practice. Surgeons obviously have an important role to play in achieving a margin-negative resection and undertaking these large operations safely. I do believe that lymphadenectomy should be done at the time of surgery for appropriate staging purposes, risk stratification, and to help inform adjuvant therapy. As I noted, despite our best efforts as surgeons, the incidence of recurrence is high, and the case fatality rate with this cancer is still somewhat sobering. And therefore, we all need to pivot more towards molecular testing and targeted therapy. I believe that all patients should undergo molecular testing of their tumor to identify whether they have an FGFR, BRAF, IDH1 mutation, because even if they undergo curative intent resection, there's a chance they're going to recur, and this information may be informative for second-line therapy. So with that, I'll conclude. Again, I really want to thank everyone, and Abdallah, thank you, and Fabrizio. It's really wonderful to be here with you virtually, and hopefully one day it'll be in person. So with that, I'll conclude. I'll be happy to entertain any questions.
Thank you, Tim. Congratulations for the excellent lecture as usual. I have I have just two questions. The first question is if we need to perform a major hepatectomy, I mean, for example, right hepatectomy, which is the best procedure to grow the future remnant liver. You know that, for example, for the Klatskin tumor, ALPS procedure is not the best one. So I don't know if you have experience. I don't know about liver venous deprivation or PVI. What do you think? Which is the best procedure for the future remnant liver growth in case of intrahepatic cholangiocarcinoma?
Yeah, I think that's a really good question. So, you know, typically we use portal vein embolization here at Ohio State. You know, portal vein embolization, as you know, Fabrizio, is really dependent, you know, on the interventional radiologist doing it. So, you know, it's not all created equal, whether there's macro, micro embolization, and making sure that there's adequate embolization of all the feeding branches to the liver that's going to be taken out, including segment 4, if you're planning on doing an extended right hemihepatectomy. If there is not adequate hypertrophy of the FLR after what we deem to be a good PVE, then hepatic vein occlusion would be our next step. So venous deprivation. So those are usually the two steps that we would take. And I have to say it's vanishingly small that the number of folks who won't experience the adequate hypertrophy using these two techniques.
Thank
So
you.
I've not done an ALPS for ICC.
Yes, me too. I have the second question about the mixed form. Do you know the mixed form between ACC and intrahepatic cholangiocarcinoma? We have in France, in Italy, in Europe, we have almost 5-6% of the patient with the mixed form. So what do you think? Which is the best management for this case? A liver transplantation, maybe, or resection, or nothing?
Yeah, I mean, as you know, that tends to be a very kind of aggressive phenotype with a poor prognosis. So patients who have a mixed tumor, you know, typically, you know, if they're resectable, I would resect them. That's typically what we do. Our transplant surgeons are not, you know, enthused about transplanting, you know, mixed cholangiohepatocellular carcinoma.
Yes, thank you.
Mm-hmm.
I saw in the audience, I saw that there is a surgeon from Strasbourg, Giannone. He wrote some paper about ACC and cholangiocarcinoma. I don't know if Giannone have a question from Strasbourg.
There is a question, in fact, from Fabio Giannone. Fabio?
Good morning, everyone. Can I speak?
Yeah, please.
Thank you for the presentation, for the lecture. Just because I have the possibility to ask 2 questions to Professor Pawlik. The first question regards systemic therapies. If you look simply at the NCCN guidelines, there's a large gap between possibilities and options in metastatic patients and in resectable cases. It means in metastatic we have durvalumab, verzolizumab, the immunotherapies, target therapies, ivosidenib, as you said, approved. On the contrary, in resected patient, and so in the curative scenario, we don't have any option. What is, in your opinion, the problem and the cause of this gap? Known that most of these alteration as EDH1 and EDH2 mutation are present in those patients who are resected and who had a better prognosis.
So, so I don't know if I completely understood your question. Maybe could you just repeat it, like the essence of it?
Yes, like why target therapies and immunotherapies now are only studied and approved in advanced and unresectable cases, and today there's no space for randomized trials in resective cases and in curative scenarios.
Yeah, no, so I think it's a good point. I mean, I think first of all, it's just super hard to study these, right? If you as you know, like you look at BILCAP, you look at Perdige, you know, it's a group of different people, right? There's gallbladder in there, there's perihilar in there, there's intrahepatic cholangiocarcinoma in there. So, you know, it's hard to even extrapolate, you know, what we can learn from these, you know, so-called like umbrella trials, where you're just tossing in a bunch of different diagnoses. And we know the genetic profile of gallbladder cancer is much different than intrahepatic cholangiocarcinoma. So I think it'd be really hard to study, you know, like IDH1 just in intrahepatic cholangiocarcinoma. You know what I mean? Because intrahepatic cholangiocarcinoma is so rare, we can't even study like capecitabine in just intrahepatic. Then you take the subset of only like 15 to 20% of people who have, you know, ICC have IDH1 mutations. It just gets difficult to study in the adjuvant setting. So, you know, I think that's, you know, why it's been studied in the kind of advanced setting. But I do think your point is interesting. I mean, as far as like patients who may be like borderline resectable, right? And do we start at some point moving forward these targeted therapies into like the preoperative setting that potentially, you know, convert people, right? Because some of the studies have shown that the objective response rate is actually pretty reasonable in some patients.
Yes.
So if you could target IDH1 FGFR2 fusions, you know, could you downsize some patients and potentially, you know, bring them to the operating room? I think that's going to happen in the future. So I think you're right on, and it's a great question.
Thank you. And the other question was, how much do you integrate the biological weight of the tumor in clinical practice? It means now KRAS mutation or TP53 mutation are an independent predictor of survival, for example. Do you think that in your equation, which leads to surgical resection, in which you put together anatomical resectability, clinical features of the patient, there's a place to put inside this equation the biological aggressiveness of the tumor, and so the result of the genetic profile. I mean,
yeah, I think there definitely is. I mean, we know like the patients who have like BRAF tumors, you know, have a more aggressive phenotype. And even IDH1, you know, I didn't show it, but there's some data that we've published so that that's associated with prognosis. So I think your point, again, is well taken that, you know, these genetic changes can not only be, you know, targetable or important kind of therapeutically, but they also have implications for like prognosis.
Thank you.
There is a question from Federico Sanguelo from Italy. Federico, if you can ask your question, you can unmute yourself. Well, he's asking.
Yes. Good morning. Good evening. You talked about the liver transplantation for intrahepatic cholangiocarcinoma. What's the role of lymph node dissection, surgical lymph node dissection before liver transplantation? What's the role of liver transplantation in those patients? Thank you.
Yeah, you're welcome. So so I kind of touched a little bit on the liver transplantation. You know, I think similar to HILAR, that you know, where people undergo an EUS and they undergo FNA of their nodes before they're transplanted. You know, I think that's analogous for intrahepatic cholangiocarcinoma. You know, I wouldn't advocate like an robotic or laparoscopic or open nodal dissection prior to transplantation, but I think, assessment with cross-sectional imaging, PET scan, and then EUS is going to be necessary, because just like perihilar cholangiocarcinoma, probably the people who are going to benefit the most are the people who are the patients who are node negative. Those patients will benefit the most from transplantation.
We have another question from Dr. Suleiman Mama. He's a consultant, senior consultant in Royal Hospital in Muscat. Dr. Suleiman, you can unmute yourself, I guess.
Say that again? You asking me, or you? I thought you were asking.
There is a question from Dr. Suleiman.
Yeah.
Hello. Thank you, Prof. Pawlik, for this comprehensive view of intrahepatic cholangiocarcinoma. To start this one, a new adjuvant for intrahepatic cholangiocarcinoma, do you do biopsy? How do you decide whether the patient to go for the new adjuvant? Do you like the genetic profile, or how do you decide for this patient go for new adjuvant, or you go directly for resection?
Yeah. So a couple things. One would be multifocality. So if the tumor is multifocal, or has a lot of satellitosis around it, I'm probably going to send them the neoadjuvant. Number two would be if, like I said, on the PET scan or on cross-sectional imaging, it looks like they have nodal disease, then I'm going to send them for a neoadjuvant. And then I think also patients who have like very high CA19-9s, like, over 1,000, over 2,000, I'd be more inclined. And then I also, I balance like the operation, right? You know what I mean? Like if it's like, a solitary lesion and it's the left lateral section and the CA19-9 is somewhat high, but the operation's straightforward, right? I'm balancing like anticipated morbidity of the operation with potential therapeutic benefit. So if someone's going to need like a triseg, big operation, it's multifocal, the nodes are positive, then I'm going to be like leaning towards like giving the neoadjuvant, because I know the risk of the operation's a little bit higher and the potential therapeutic benefit's a little bit lower. So that's all I'm always thinking, like, straightforward operation, lower risk. Then I'm looking at the tumor specific factors, or, very difficult operation, and some of the, biological factors are suggesting this is an aggressive tumor, that I'm going to head more towards the preoperative therapy. There is a clinical trial that's open now here in the United States. That's a randomized trial that is basically randomizing patients directly to surgery versus preoperative chemotherapy. But I think just like pancreas cancer, again, there's not been any great data to show that there's like an overwhelming survival benefit to preoperative therapy. I think most of us agree it just allows like better selection. But I've always argued, what's wrong with that? I want to select the people I can help the most.
Do you do the biopsy before chemo, neoadjuvant?
Yes. I mean, no medical oncologist that I know of will give, chemotherapy without a tissue diagnosis.
And how do you do that if the patient need like you want to do like FLR augmentation before, and you want to do also neoadjuvant? How do you solve this issue?
We want to do hyperalimentation, did you say?
No, I mean that FLR augmentation, like portal vein embolization, or
yeah. So yeah, so we'll do it, during chemotherapy. Maybe they'll get a couple cycles of chemotherapy, and then we'll get a repeat scan, make sure there's no progression either within the liver, outside the liver. That surgery looks like it's a go. And then we would do the portal vein embolization at that point, reinitiate chemotherapy, just like we do for colorectal liver mets, and then after 6 to 8 weeks, get another scan and assess the hypertrophy and the disease progression. And then if there's no progression, the liver is hypertrophied, then we go.
Thank you. There is another question from Dr. Noreen, again from Muscat. Noreen, you can unmute yourself.
Hi, good evening. Do you hear me?
Yes.
Yes.
Hi, good evening, Prof. And thank you for your presentation. My name is Noreen. I'm a liver transplant surgeon from Royal Hospital. I just want to ask you a question, just utilizing that you're here. I just need your opinion in it because I've operated on 2 hilar cholangiocarcinoma cases in which there was kind of, it's not a weird observation, but what do you think in such scenarios you would do? Like I did PTC for them prior to the surgery just to drain the right side. They were E3 bismuth. And while usually I do a diagnostic laparoscopy before proceeding to such cases. And my observation was like during these 2 cases, I've just found that there were metastases around the PTC site insertion only, without having any more disseminated disease elsewhere. What do you do in such cases? Because I felt really bad. Both patients, they were very young, and I didn't know what to do, and I just abandoned the case for the fact that they were proven to be metastatic while doing the frozen section.
Yeah, it's a good question. So, we wrote a paper looking at like endo versus percutaneous drainage, and probably because the sample size was small, we didn't really see a difference between like risk of like peritoneal metastasis, because your point is exactly that by doing the percutaneous approach, there is a concern that you're going to get some seeding along the catheter. So I guess the first thing is, I always make sure, like, does someone really need percutaneous drainage? I know in the past, when I was at Hopkins, like everyone got a PTC. Now I feel much more comfortable, with advanced endoscopists just putting in like endoscopic drain. So, and usually they can get both sides drained and even like secondary biliary radicals drained. And so that's kind of my preferred approach. That being said, I don't know what the right answer is. I mean, I think, if there's peritoneal metastasis, even if it's just around the PTC site, I would be nervous that, the horse is so-called out of the barn. And while you can only see the metastasis around the catheter, it would suggest that, there has been access to the peritoneal cavity. So I don't know if there's an option at that point, which sounds like you did abort, and then treat the patient with additional systemic chemotherapy, and then at some subsequent interval to go back and do a laparoscopy to assess whether there is truly any peritoneal disease. And if you don't see any at that time and you do peritoneal washings, that at that point you could reassess for transplantation. So I guess that would be my kind of recommendation off protocol, right? Is not do it then, but like I said, wait, give more chemo, then come back, do a laparoscopy, washings. If that's all negative, I would consider it. I don't know. What do you think of that?
Yeah, because the first patient, I don't know what happened with him. It was during my training in Vancouver. But the second patient, I'm just recently, his bilirubin was 300 when I started, treating this patient. And now his bilirubin is normal with chemotherapy. And he came for a change of PTC. And I was surprised about the way, the CT scan looks really well. And even I drained the left side completely. It's with another. I stented him and the left side, and I placed the PTC over the right posterior sector just to drain his right side because it was pouring a lot of bile, like 400 to 500 per day. And I was surprised after 3 months of chemo. His bilirubin is normal. His CT scan, there's no progression. There's nothing there. So that's why I was wondering what to do next. Shall I just proceed with another diagnostic lab, go back? Because he's very young. I just want to be more aggressive with him.
Yeah, I don't know. Like I said, I think, doing another laparoscopy with washings, because that what you're going to be able to see is one thing. But if you do peritoneal washings and they spin it down and the cytology is negative, I'd feel more comfortable, right? Because then you got nothing, you got nothing that visually you can see on laparoscopy, and then the cytology is negative. Then I'd say, well, let's do it.
Oh, okay. Thank you very much. Thank you.
Yeah. That.
There is another question from Celeste Del Basso from France.
Yes, the last one, the last one.
Celeste?
Yes, I'm here. Thank you so much, Professor, for your presentation. I have a really sample question concerning the surgical strategy in papillary cholangiocarcinoma bismuth type 1. Is it liver resection always mandatory in this case, or we can maybe perform a less invasive resection?
Yeah, I mean, I still subscribe to liver resection. You know, if you look at the data for like a bile duct only resection, the incidence of recurrence is significantly higher. And so, you know, I subscribe to like 1, 2, 3A, you know, they're all going to get an extended right, and then 3B is going to get like a left or an extended left, and then removal of the caudate lobe, because there are some biliary branches that drain directly into the caudate lobe from the common hepatic duct. So that's what I would recommend. The only other thing caveat is that when someone has like a mid-duct cholangio, always keep in mind that it could be a gallbladder cancer. You know, that it's not, you know, totally uncommon that people can develop a cancer in the infundibulum of the gallbladder that tracks down. And so you think it's type 1, you know, bismuth, but really it's a gallbladder cancer. But that's kind of my my recommendation.
Thank you so much.
You're welcome.
Thank you. Great talk. Thank you, team.
Yeah, thank you. Thanks, everyone. I really appreciate it. It's great seeing all of you.
Yeah, it was a great pleasure, in fact, and I think questions will end Nibar with your talk and your wonderful, I would say, presentation. It was a pleasure for us, in fact, to hear from you, to have you with us in HPB Cafe. So,
My pleasure. I hope to see you all in person soon. Stay well.
Yes, thank you.
Good job, Ola. Good job.
Thank you. See you
All right,
soon.
everyone.
Thank
See you
you.
later. Bye-bye. Bye-bye.
Bye.
Thank
and
you.
thank you all
Thanks.
for
Bye.
us.
Thank you. Thank you, Abdullah.
Welcome.